Hello and welcome to everyone. We're about to start the session on health workforce financing. It's a pleasure to have you all here. Where the format of this panel will be that each panelist has 5 minutes to present, and then we'll have about 25 minutes for discussion because we think that this is such an important issue and we want to be able to answer people's questions and hear about people's work in this area. And I will introduce myself first. I'm Dr. Kate Telenko. I'm the founder and CEO of Corvus Health, which is a global health workforce firm. And previously, I served as the director of USAID's Global Health Workforce Project. And we all know that financing health workers is so important. In fact, the World Health Organization and most major donors have identified health workforce as one of the largest challenges to achieving universal health coverage. Yet despite this, few organizations, few people are actually implementing, researching, thinking about how to finance health workers. And it's important that when we think of financing health workers, we think of the entire labor market or the entire health worker life cycle. And what you see on the screen is an example of the health worker life cycle, because it's important that we finance the entire part of the health worker life cycle. Natasha, could you put it on presentation mode, please? So here we see an example of, oh, that's the second slide, if you could go to the first slide. So here we see, the first section of the health worker life cycle. We know that policy, regulation, and planning are not well funded. We also know that education of health workers is not well funded. This is what we see here. We see that they're financing breakdowns, insufficient investment in STEM in schools, particularly in rural areas. So rural graduates can't qualify to enter health professional school. We also know there's significant labor market breakdowns in the pre-service education of health workers, nursing school, medical school, pharmacy school. And we know that there are solutions such as scholarships, loans. Kenny and Janet will be talking about today, pooled purchasing of pre-service education inputs. This is what Appleseed Education does, as well as impact investors. Corvus Health has an social impact bond on preventing dropouts of health workers, because we know in many health professional schools, the dropout rates are 60% or higher. Next slide, please. So next slide, and if you could put it on presentation mode. Okay, so the next slide shows further parts of labor market elements, the market breakdowns we have, and some of the potential solutions. If you could put it back on that slide, please, Natasha. So we have licensure and certification. We know that some health workers are not able to practice because they literally don't have the money to pay for their license. We know that like microloan scholarships would help for this. We know that there's that in any health system, the wages of health workers are the largest single line item in the budget, larger than medicines, larger in infrastructure, and so it's the largest part of most systems budgets. And so we know that many governments will need to actually put in sin taxes, which taxes on sugary drinks, taxes on alcohol, things like that, to generate money to pay for health workers. We also know that we need to encourage self-employment of health workers, particularly of midwives. The challenge of maternal mortality and newborn mortality will be solved with self-employed midwives. Natasha, if you could please put it to the first slide. And then also for retention of health workers, we're going to need innovative forms of financing as well. So I will now introduce our first speaker. We've had a slight rearrangement. Our first speaker is going to be Sarbani Chakraborty, and she is the founder and CEO of Goals for Health, a global health advisory based in Geneva, Switzerland. And she works with public and private sectors to advance health financing and innovative service delivery models for integrating NCDs into UHC. And so she'll be talking about a health financing framework for tackling health workforce gaps in NCDs. So please, Sarbani.
Thank you so much, Kate. So Natasha, if I could have my first slide. So thank you, Kate, for telling us it's just 5 minutes, which is good. So I'll try to, it's like a lightning talk, and I'll also try to be a little provocative so that during the Q&A, we can have more of an engagement. So while Natasha is pulling up the slides, one thing I want to say is Kate made a really important point about focusing on the health workforce. I am more of a health financing, health systems person, and for me, the health workforce is the most important investment in the health system. So when governments look at health systems performance, they should be looking at how to fund, nurture, preserve, and grow the health workforce. So my presentation looks at that. And the second thing I want to mention is that I look a little bit more at innovative financing. So I think we can move to the next slide already. So I look a little bit at innovative financing. In fact, this is a piece of work that Kate, Natasha, and I are also doing together right now for the NCD Alliance. And so I would just like to present quickly what is innovative financing. And it's quite relevant to our discussion today because for I think more than a decade, we have been talking about innovative financing. But the reason why in global health, we started talking about innovative financing was for two reasons. One is countries recognized, especially if you look at NCDs, that only public financing was not going to cut it. There has to be public-private. And so mobilizing private resources became really important, and that fell into the definition of innovative financing. And the second reason is there was increasingly discussion of moving from passive to strategic purchasing. And strategic purchasing can be done by the World Bank, it can be done by philanthropic organizations, it can be done by governments, it can be done by health insurance funds. So what does it mean when you purchase strategically is you're thinking about what you're purchasing, from whom you're purchasing, for what you're purchasing, and finally, how are you holding providers accountable? And just I would like to finish by saying, why is this important to our discussion today? Because I've spent 30 years in this profession. I worked in the World Bank, and we were advising governments on how to improve the health system. And one of the things I learned is that provider autonomy is really important, because right now there's a situation in many countries where the public sector doesn't have a lot of opportunity to move resources around. And that creates a problem also in terms of attracting and retaining the health workforce. So maybe the next slide, please, Natasha. So as I said, this is work in progress. So one thing that I'm trying to do is to match different types of innovative financing to application to the health workforce. And this is work in progress, but I'm finding many examples, basically. So blended finance, to give you an example, public-private partnerships, the International Finance Corporation does this quite well. Private companies like Philips, General Electric, a lot of people are engaged in this area. What they're doing is basically partnering with the public sector to do things that would support health workforce development. But I would like to say one of the things I'm not finding, which is the point that Kate made, is the continuity is throughout the life cycle. I'm finding a lot of specific interventions for specific groups, but people are not connecting the dots. So that is already a takeaway from me. For me, is that it's interesting to do innovative financing, but if you only pick a piece of it, pick it with an objective to impact the whole life cycle, not just that little piece. There are many other mechanisms. One thing I would like to highlight, because I'm going to end with that, is insurance-linked financing. And insurance-linked financing takes me to the concept of universal health coverage. So you can move to the next slide, please, Natasha. So I would argue, similar to how Kate has argued, that you need to look at the life cycle when you look at health workforce investment. When you look at health systems and supporting health workers, you also need to look at the entire health financing cycle. Just picking an innovative financing mechanism is not going to solve the problem. So we need to start from understanding how much a country is really investing in health. Because if you look at sub-Saharan African countries or South Asian countries, the investments for NCDs is so low, then you wonder, how are we actually going to get the health workforce up to speed and fit for purpose to deliver NCDs? The second issue, which I think Corvus Health works a lot on, which is this whole issue around public sector reform. So you have ghost workers, you have absenteeism. And if you don't clean that up, whatever money you invest is not going to get you your best bang for the buck. But then it's not enough. Once you've got those numbers right, how you incentivize healthcare workers to deliver to their maximum capacity becomes important. And here I would like to only highlight two things, and that's where I'll end. One, I'm seeing an increasing trend in South Asia and in Sub-Saharan Africa around social enterprise. There are a lot of young entrepreneurs who are getting into this area. In fact, not just in low resource settings. I recently read of an example in Austria, where the Austrian government, with a loan or a grant from the European Commission, is encouraging social entrepreneurs in Austria to set up primary healthcare practice in rural areas. So for me, that incentivizing becomes really important. Incentivizing for innovation becomes important. And finally, I'll end with purchaser-provider split, because the whole concept of separating purchaser from provider is the purchaser not only holds the provider accountable, but also gives the incentive so that they can deliver. And if you don't have autonomy, you're not going to be able to move your health personnel around. You're stuck because somebody's told you need to have 6 nurses, 7x7, but you want to build a multidisciplinary team. How do you do that if you're working under a very, very constrained environment? So I'll stop there. I hope I've given you a flavor. This is obviously a very complex topic, but maybe we'll come back to it during the Q&A. Thank you, Kate. Back to you.
Wonderful. Thank you so much, Sharbani. And your mentioning of the fragmentation of financing for the health workforce is actually the perfect introduction for our next speaker. So our next speaker is Dr. James Asomani, and Professor Asomani is the head of WHO Afro's health workforce team, where he works on health workforce for 47 countries. And this year he developed the Africa Health Workforce Investment Charter, and also he received the Investigators Award for the Society of Medical Decision Making. And Professor Asomani is going to speak on fostering public-private partnerships in health workforce investments using the principles of the African Health Workforce Investment Charter. James.
Thank you very much, Kate, and a pleasure to join you today for this discussion. So in 5 minutes, I will try to just signpost, and eventually we can have more discussion during the Q&A. So can we move to the next slide, please? Next slide, please. Yeah, just to give you an overview, in the African region, despite producing more than 255,000 new health workers per year from 4,000 institutions, of which the private sector is contributing 40%, we are adding more workers, but facing a big shortage of 6.1 million health workers. Reason is we do not have enough money to be able to train more and absorb. And even those trained, 27% are unemployed, while 1 in 10 are already abroad. Many more want to leave. So the problem in Africa really requires that we need to innovate and work together to invest in health workers. Next slide. Like I said, the private sector is in, please click the next one. The private sector is increasing its investment in workforce training and education, even though there are still some concerns regarding quality. But when it comes to employment, they are able to absorb just 22% of the workforce. And that leaves a big gap for the public sector to be able to absorb. And the public sector, as everyone knows, is constrained financially. Huge rising costs of credit and also inability to mobilize resources internally has left many governments unable to invest more in health workers. And this is why they must work with the private sector and all other partners. Next slide, please. So our modeling has shown that for Africa to be able to even absorb the current workforce, we need about 43% additional budget. And if we were to even cut the shortage by half, it's about 77% additional budget required. This doesn't seem very feasible from government sources alone, and that is why we need to work together. But to put in context, it's just roughly 2% of GDP. Next slide, please. So to be able to address these issues, we think that there are 4 main areas to look at: invest more and efficiently in the health workforce, train more train better, and employ. This is key to addressing the labor market failures that Kate has already mentioned before. So let's look at what the Workforce Investment Charter seeks to do and how that can be leveraged to foster public-private partnership to be able to address these workforce challenges. Next slide, please. The Workforce Investment Charter, which was adopted and launched in May this year, has 5 main principles: government leadership, evidence-based prioritization, alignment and synergy, stimulating investment, and ensuring sustainability. Next slide, so that we can see how we link these ones and the role of the private sector. First, the Charter commits governments to take the leadership and stewardship to bring all partners, including the private sector, together to analyze its own situation as for the country, to prioritize what to do. We can't address all the issues in one go, to prioritize. And based on the prioritization, have policy dialogues to be able to align and synergize our efforts. And that will lead to us stimulating investment from both government partners that are giving money in terms of grants, but also those investing for profits. And all of that should be linked to ensuring sustainability for the futures, not just long-term, small changes. Next slide, please. To be able to do this, the main thing that the private sector can come in is, let's generate the evidence together with the government. Let's dialogue to agree what matters. Let's have one plan where the private sector's interest can be put in. Let's put together our commitments in terms of investment into something formalized through a compact. And we can invest in education, in jobs, ensuring efficient use of the resources, but also holding each other accountable. This is how we put in a more linear form on how we operationalize this in the country. Next slide to show a very quick example. So an example is about Zimbabwe, where they did the evidence generation in 2022, came up with a strategy in 2023, agreed with the partners to sign a compact with commitment in 2023, and that was finally signed this year, last month. And that compact is promising a lot for Zimbabwe. Next slide. In that particular compact, Zimbabwe is going to expand and refurbish 27 schools to be able to produce more than 7,000 health workers. It's going to create 14,000 more jobs in 3 years and increase workforce salaries by 22%, while putting money in about 23,000 community health workers. This commitment has led into having about $463 million in 3 years. Some contribution from the Global Fund and from the government and other partners have come in, but many other areas require the private sector to come and invest in it so that the compact can be realized. Next slide, please. So what can the private sector do? What are the opportunities? First, follow the principles of the Charter, set the agenda with the government through the evidence generation and dialogue processes. 2, ensure the private sector needs are included in the investment plan of the government. 3, identify interventions the private sector can leverage to pursue public-private partnerships. The governments have already committed to it through this charter, and it is now an opportunity to leverage on it to be able to invest. 4, the private sector is better in resource mobilization than governments. Mobilize the resources through different mechanisms. And finally, seek to serve on the investment advisory committee so that the private sector interests can be best served. Can you go to my thank you slide? I would like to thank you, and we can discuss more on this during the Q&A session. Thank you very much.
Great. Thank you so much, James. Really appreciate it. So our first 2 speakers, Sarbani and James, talked about the entire health labor market and the importance of working across the entire labor market. Our next 2 speakers will focus on financing health worker education. So our first is Ketty Lai from Arudify. And Ketty is the co-founder and senior vice president for business development at Arudify, an education financing platform operating in Indonesia and the Philippines. Arudify's mission is to make education affordable and to build a better future for youth in Southeast Asia. With her background in microfinance and impact investing, Ketty has led Arudify's expansion, working with more than 200 school partners and serving more than 50,000 students. Ketty.
Thank you, Kate. Yeah, it's an honor to be able to speak as part of this panel. Thank you, Sarbani and Professor James, for your sharing as well. Definitely learned a lot. Thank you, Natasha. Yes. So just continuing off what the other two speakers have mentioned, what Erudify does is to provide financing in Southeast Asia. The biggest reason is because we saw that in Southeast Asia alone, there's 90 million youths being ignored by banks, as seen here. And we specifically focus on Indonesia and the Philippines right now, mostly because us and the co-founding team are from there. So I'm born and raised in Jakarta, currently based there as well. And what we've seen is that there's such a big need for a financing, right, beyond what traditional banks and governments are providing. So enrollment rate in tertiary education has been low, and was just chatting with Kate a couple of days ago that especially in the healthcare sector, we're seeing a bigger need for that, and not necessarily for the medical degree program. Certainly there's a need for that, but especially in the nursing program, where a lot of workers, young workers, young female workers, right, they tend to gravitate toward this job because of the caregiving nature and also just the social perception of it tends to be more positive, and it's definitely a leg up for a lot of their families. So a lot of these 16, 17-year-old girls, right, women are deciding wanting to be nurses, and we're also seeing a trend where there's more and more need for caregivers in countries outside of Indonesia, outside of Southeast Asia. So one trend that we're definitely seeing is, for instance, a huge labor need in Japan with an aging population that needs more caregiving. And locally, domestically, it's just hard for them to provide that. They're recruiting a lot more from places like Indonesia and the Philippines. But the biggest need that we're seeing is really the training, as Professor James and Sarbani has mentioned as well. And here, as you can see, is one of the quote is Yuna. So she's one of our students that we've been able to finance. And really her biggest struggle when we first met with her was she just couldn't afford the tuition fees, right, to enter these medical degrees or nursing programs, because there are other family needs to be met. A lot of them, even at the young age of teenagers, really are really the breadwinner for their family, unfortunately. And from Erudify, we've been very blessed and grateful, right, that we've been able to impact tens of thousands of students. And in Indonesia alone, these are the impact numbers, and the Philippines over as of last year. So we've grown, and we're actually serving more than 50,000 students now, and hope to grow more. So next slide, please, Natasha. And what we're seeing is that, yes, as the previous speakers have mentioned before, there needs to be more of a private sector role, right? Obviously, the government and a lot of the other stakeholders have played a big part in it, but there's so much more for the private sector. And as a startup fintech company, that's where we're trying to bridge, where we bring in more innovative financing options, right? Where we focus on giving, especially those, so about nearly 90% of our borrowers are first-time borrowers, and these are young students. These are basically teenagers, right? Either so it would be sometimes it's themselves paying off for their schooling or their families. So what we're seeing is that in Indonesia and the Philippines, at least, the status quo options are simply inadequate. Universities or schools are not set up to be financial institutions, but a lot of them have had to take that on because there's just not a lot of other options other than scholarships, for instance. But then that that usually comes from the government, and as many of us know, that's also limited. Scholarships tends to be merit-based, and which is understandable, but that also means that a lot of people who might just not have had the leg up to have the training, right, would not qualify for it, or they might just, miss that line, and yet they're just not able to get that scholarship. Or even some of the scholarship that are provided are just not going to cover everything. And so there's also the role of the traditional lenders, right, traditional bank institutions. And at least in Indonesia and the Philippines, what we've seen is that they tend to not really expand in the education loans, and yet there's a huge need there. And even those who are providing it, they tend to have higher fees, long processing time. It takes a couple weeks, whereas for these students and the schools, you know, we, at least from our side, we try to do it within days so that you can get fast response. And we cater and customize all our operational details for the students and for education needs. So just next slide briefly, this is the role that we play. So just an overall sort of value that we hope to bring to the table is really to be that bridge between schools and students. So a lot of basically our business model and Eridify is that we partner with the schools. So we really want to be part of that ecosystem, right? And especially in this context, healthcare programs that we see are rising up. And I think what's interesting about this is that it's not just the multi-year degree program of medical training, but we also see vocational schools really providing shorter training, 6 months, a year, 2 years. That's very catered towards specific skills, but able to churn out caregivers, nurses that can either serve in the country, work in the country, or be sent abroad, because there's a huge need there. And when they do so, even when they stay locally and got employed by the local hospitals or clinics, it really is a leg up. It really makes a difference in the life of these students, of these men and women and their families. I think that trickle effect, that domino effect, it is hard to quantify, but we do see it just from the stories that we hear from the students that we've served. And then from the school side, obviously, it also provides them a sustainable way to really expand, to really cater to more students without having to take on the operational burden and the financial risk of having to provide more flexible payments, installment payments that often these students have. So I think just to close my section off, I think what's been interesting is that recently we're also working with a school that has created a joint venture with an industry in Japan, and they're focusing on training health workers. So it's very specific training. But it's quite short, within 6 months, catering towards Indonesian students that will then be recruited and employed in Japan, partly as caregivers. And we're working with them as the financing partner. And a lot of the financing scheme that we've been building, because of the multi-party partnership between the school, industry, and ourselves, allows the student to be able to just pay a very minimal fee within the first 6 months, really less than $100 even. And then when they get employed and have that income, that's where we can run payroll deduction, and a lot of the high repayments are paid back after they are employed, which opens up so much more opportunities for these students who tends to come from lower income background, not qualified for a lot of other credit options, but yet really are hungry to be trained, hungry to work. And when they get this opportunity, it can be life-changing for the students and the families. So that's really exciting for me, and was sharing it with Kate, and hope to scale that further. Yeah.
Great. Thank you so much, Katie. And I want to remind the audience, please put any questions you have in the chat, because we'll have time for our speakers to answer the questions or any comments that you have. And I wanted to point out that what's really important about both the Eridify and the program Dr. Janet's going to talk about shortly is they're sustainable. These are not donor funded. They they won't end in 4 years when the project closes down. The organizations are able to make a profit and be sustainable, and that's so important in this age of shifting priorities in global health and shrinking budgets. And also that these programs are win-win. The students benefit, the students who weren't able to go to school before now are able to go to school, and also the schools benefit because they get more students, and also they have the schools had a more consistent flow of funding. Whereas in the past, if the students were unable to pay, the schools might have budgetary problems. So these systems really address a number of issues. So our next speaker is Dr. Janet Muriuki, and Janet is a medical doctor, health systems and workforce specialist with over 20 years of experience in the health sector. And she provides strategic and technical support to health programs across Africa and Asia on human resources for health, service delivery, and quality improvement. And previously, she was chief of party for the USAID-funded IntraHealth-led Human Resources for Health project in Kenya. And also she was technical director of the Health Workforce Kenya mechanism and the Health Workforce Capacity Bridge program. Janet.
Yes, good morning, good afternoon. Thank you, Kate, for that introduction. So I think building on the footsteps of the other presenters, I'll be sharing with you an education innovative approach. This is the case of Afya Elimu that IntraHealth International has implemented in Kenya. To start off is just to recognize, I think, what was mentioned about Southeast Asia and what is happening in Sub-Saharan Africa, and in particular East Africa, is very similar. We are all suffering from a high rate of youth unemployment, and within the region and specifically in Kenya, severe shortage of health workers. Next, please. So the Afya Elimu Fund is in particular trying to address the workforce gap currently from health labor market analysis that the Ministry of Health Kenya and WHO Afro, led by Dr. Samani, collaborated on, did show that Kenya is only at 68% of achieving the SDG of 44 health workers per 10,000 population. They still need to continue producing workforce, has already been cited, and this is critical in support of primary health care. However, there's a challenge in the medical training colleges and universities because households are not able to afford the tuition fee that is required by the students who are part of the family members, really to ensure that they can complete their education without dropping out. In the case of Kenya, what we did is that we engaged as IntraHealth with the Ministry of Health, with the Ministry of Education. We also brought in the Treasury, we brought in the private sector, and had a roundtable discussion in how we could put in place intersectorial collaboration. And this resulted in what we call now the Afya Elimu Fund, which was resources being put in the Ministry of Education, the Higher Education's Loans Board. This body routinely would give loans of 4% to students to pursue degree courses. But the bulk of our health workers are actually those from the mid-level colleges where we have the certificates and the diplomas. This cadre had been neglected, and this is where we have our nurses, our clinical officers, our nutritionists. These are the mid-cadre level. So they were not being supported with these loans. So we worked with all the stakeholders and provided their loan facilities through the Higher Education's Loans Board as a vehicle for sustainability and as a vehicle in which follow-up would be undertaken to ensure once the students graduated, they would now be given a grace period of 1 year and subsequently start repaying their loans while employed. Next, please. So this is the Afya Elimu Fund. Over 8 years, we were able to raise 30.6 million US dollars, which is about Kenya shillings 3 billion. And that is because we had majority of this funding that we advocated from the Ministry of Education to bring on the table to support the mid-tertiary student. We also worked with funding from USAID. This was just catalytic funding through projects that IntraHealth was implementing between 2012 to 2021, and that was about 5%. The rest of the contribution was really from local foundation, the banks and the businesses that were able to also put in kitty into the Afya Elimu Fund. The outcome of this was over 40,000 students were trained. About 3,900 have graduated. We did work both at the national and the sub-national level to engage the Public Service Commission and the boards to employ the graduates, and about close to 5,000 had graduated. The repayment we started seeing from the graduates upon the grace period. They began repaying their loans, and we had about 2.24 million US dollars paid back by our students, which is really a great effort by the students to begin repaying, and this continues to be sustained. What we did towards the end of our project as IntraHealth, but we do continue to monitor this fund, is hand it over to the Ministry of Education, the Higher Education's Loans Board. And this was to really say that this is no longer a project, this is an initiative that must be driven by government, and government must continue to look for resources to continue revolving the fund. And we realized that there were partners like the Kenya Medical Training College, which churns out a bulk of Kenya's health workforce. They could put money on the table. They also reached out, the Higher Education's Loans Board and Johnson & Johnson also put resources on the table. And this has continued to keep the fund evolving, and we still continue to see successes, more students graduating and being able to seek employment, both in public sector, but also in the private sector. Next, please. So a case point is Osoro, who is a student. Who was a student and a beneficiary of this product. He was from low-income family, but he was really lucky that he was identified through the mean testing instrument that was utilized by the Higher Education's Loans Board to sift through and critique the students that met the criteria. Osoro was one of them. And upon completion, the interesting thing that he set up his own clinic. He's a clinical officer. He opened up his own, I'll call it like a dispensary in a rural part of Migori County. And he was able to now subsequently, after about a year or two, employ other students who had also gone through the Afya Elimu Fund. He is repaying his loan. Those that he has employed are also repaying the loan. Him working at a dispensary as a clinical officer, he is able to actually, he's providing primary healthcare to that local catchment. So these are really the on-the-ground effects of what a collaboration between government, the private sector could really result to. More health workers serving in both public and private sector, but addressing primary healthcare at the grassroots. Thank you very much for listening.
Great, thank you so much, Dr. Janet. And an interesting thing about Afya Elimu is some of the private hospitals have started putting money into the fund so that they can bond health workers, pay for their education and employ them afterwards. So that's just another way that it's become sustainable. So all of our speakers have spoken, and so definitely put your questions in so the speakers can answer them. And in the meantime, I have a couple of questions for the speakers. So first is for Dr. James Asamani. James, you presented the case study of Zimbabwe and how they are working on the financing of health workers and creating that plan. Could you discuss what are some of the forms of financing that they're using to train and employ more health workers? For example, are they using earmark taxes? Are they using, more of the general budget? Are they partnering more with the private sector? So we'll see, James is still muted. There you are.
Yeah, thank you, Janet. So in the Zimbabwe Compact, the bulk of the commitment is coming from the general budget, but they've indicated that they are very open to concessional financing and other mechanisms, including public-private partnerships, particularly in the area of education, getting more schools and expanding the infrastructure to educate more health workers. Yeah, so that is what they are exploring for now.
Wonderful. And actually, another question for you. The political will and, having a champion is so important when you're trying to address these systems challenges as opposed to sort of vertical challenges. Who was the champion in Zimbabwe, and how, politically, were you able to create this financing plan?
Okay, so in Zimbabwe, obviously the Minister of Health is champion, but when they got to the cabinet, it was actually the Minister of Education who was the lead, who led it to convince cabinet to get cabinet approve it. So we can say that they are a group of champions, not just one champion. Yeah.
Well, that's amazing to hear that the Minister of Education got involved, and we see from Ketty's and Janet's talks, how important education is. So for Ketty and Janet, could you please address the default rate that you have for the loans, and what are the number one causes of default, and how do you think that could be addressed?
Sure, I'm happy to answer first. So the default rate for our overall portfolio, I think it's less than about 3% or less than 5%. So it's still very manageable. I think various factors have been a major challenge, right? Obviously the macro econ and post-COVID has been challenging, and I think a lot of it is because throughout the COVID period, a lot of the families have had to take perhaps more loans that they would have, or more financing assistance than they would have had to otherwise. So that have had been a challenge. I think what's interesting though is that at the same time, having partner with the institutions, with the schools, we're seeing more of our partners, especially as the partnership matures, they know us better, they've seen the impact and traction to have more skin in the game, in the sense of some of them have, agreed to take on the fees so that students don't have to pay any of the fees, or are willing to take first loss, so that's certainly very encouraging to see a deepening of the partnership in that sense.
Wonderful. And Dr. Janet.
Yes, thank you very much for that question. So on the part of the Afya Elimo Fund, one of the things that has led to low default rates is that it has been anchored within the Higher Education Loans Board. This is a parastatal of government. And all payment of the Higher Education Loans Board is actually mandatory. So employers are expected on onboarding of the new employees to ask them whether they have any Higher Education Loans Board. And even if the employee reports no, the employer is required to screen or submit the employee's name into the Higher Education Loans Board database, and they would discover that their staff is actually still having a loan. And the employer must deduct every month a percentage agreed upon with the employee to enable the Higher Education Loans Board to recover. So this ensures that even those who are working in public or private, the Higher Education Loans Board is able to recover. And this is what has led to a low default rate. So the default rate is usually maybe those who don't get employed at all for one reason or another. But we know there's really high demand for health workers. And as per the statistics from the Higher Education Loans Board, health workers are the ones who are best at paying back their loans. Thank you.
So comparing health workers to students who graduate with other degrees, absolutely. So my next question is for Sarbani. How can we monitor the effectiveness of health financing frameworks in addressing both the health workforce and NCDs? What metrics or indicators should be tracked to measure progress and ensure accountability?
So Kate, I think it's context specific, right? So every country or region has its own specific issues or problems related to health workforce. So I would say that even before you develop your indicators, you need to have a very, very good understanding of the labor market. So it's very country specific, but some of the things that are coming out in our literature review is, especially in Sub-Saharan Africa, Eastern Mediterranean, etc., there's a shortage, right? So did you fix the problem of a shortage? If there are no health workers, they're not going to be able to do NCDs. They're not going to be able to do anything at all. The second tracer is the workforce trained in NCDs? Because as far as I know, and Kate, you're even more of the health workforce expert here, but I've been just reading a lot on it, that a lot of pre-service curriculums do not include NCDs, for example. So there are doctors and nurses coming out who do not yet know NCDs. So that would be another important. The third is, what is the balance between specialists and primary healthcare? How does the country want to really frame the NCD issue? Because there's a lot of prevention there. There's a lot of work that can be done at the primary healthcare level. There's a lot of task sharing which can be done, but the referrals must be also done on time and correctly, right? So I think those are sort of the three, is like, is the work healthforce there? Are they NCD competent and prepared? Are they given the supportive environment and the tools to do the job? And are referrals happening on time and correctly? So those
Okay.
would be my list. Thank you.
Thank you. So my next question is for James, but it also is open up to all the panelists. So James, you work with 47 African countries to work on the financing of health workforce. What are some of the innovative forms of financing that you've seen, including forms of financing that the audience may not have heard of before?
Thank you, Kate. So there are different countries have approached the financing of health workforce in different ways. So there are some countries where we've seen specific taxes and levies that has been used to finance health workforce. For example, during the COVID-19, we saw countries that introduced a COVID-19 levy, part of which was dedicated for motivating and incentivizing health workers. We've also seen in some countries where they have sought to use loans, for example, concessional loans, to invest in health workers, particularly in the area of education. And then we've also, for example, like in Benin, where they, with a loan from the Islamic Development Bank, they trained health workers and use the same money to enable the health workers to set up their own private practices in rural areas. And there was a mechanism for sunset, and by sunset period, the health workers who were trained were expected to either be independent, practicing in their own facilities in the rural areas, or they had a route to go back into specialist training. Then we now also begin seeing a clamor now for countries saying that we should consider having a more centralized approach to pooling funds. What has been proposed as the Africa Workforce Investment Platform, so that private entities and other institutions that want to invest in health workers with some level of return that will come to them as profit can put in their resources, and those that want to put as conditional grants for specific deliverables in health workforce can put in also their resources, so that countries can access the grants on the condition they are able to also access some of the conditional loans to implement agreed upon interventions and pay the loan component over time. We're beginning to see that, for example, using the Health Impact Investment Platform, a good example in Ethiopia, where they are investing in primary healthcare and the workforce is a component of it.
Wonderful. Well, thank you so much. We're actually now out of time, but before we leave, I want to make the comment that health financing doesn't have to be money per se. It can be other things such as support. For example, private midwives able to call a helpline to get technical assistance and have that service be free. Or, for example, Rwanda, private midwives are allowed to use public health facilities. For example, if they need access to a labor and delivery room, they're able to reserve that for free. And so that's leveraging these existing resources. So we've had 4 presentations from a wonderful set of speakers, 2 talking about the entire health labor market and how to address financing challenges sustainably across that entire labor market. And then 2 of our speakers addressing the sustainable financing specifically of the education of health workers. And we know that the biggest component of financing health workforce is employment and retention. We also do need some financing for the Ministry of Health departments that do the planning, the policy, and then the regulation as well. But I want to thank all of our speakers and thank all of our participants. And I hope that we can continue this discussion on this vital issue of how we can finance universal health coverage through training and employing health workers. Thank you.